Good afternoon. So I was just looking through the program book and suddenly keratoconus has become very, very important for us. The entire Cornea 1 session has papers only on keratoconus, which was probably not so around 5 to 10 years back. So I'm going to discuss another aspect of keratoconus, the impact it has on patients with the emotional, mental stress that the patient has when they are diagnosed with keratoconus. So I have no financial interest or any conflict of interest to declare. So a patient of keratoconus, when he's typically diagnosed as keratoconus, is a male patient, generally a male patient in India, belonging to either a student or a professional, age group of 18 to 25 years old and coming from a middle or upper class background. This age group of 18 to 25 years is what is known in psychosocial development as an emerging or young adulthood. And they are a vulnerable population because they are at an epoch time of their life. They are defining their life goals, appearing for exams, building up a career. Someone would have completed their career and started off with a job and starting businesses or their careers, professionals. So it's an important phase in their life. And when they are diagnosed with a disease that is said to be non-curable, would have significant morbidity, they take it very, very in a difficult way because their mental maturity is still not mature enough to deal with it. We must remember that they are otherwise an healthy individual and may be encountering ocular disease or any health-related issue for the first time. So we wanted to see the prevalence of anxiety and depression in patients with keratoconus, and this was a cross-sectional study that we did in our institute. We did a sample size calculation, and we also we took ethics clearing committee clearance. So we included all patients of keratoconus who were 18 years or more and who had been diagnosed with keratoconus for at least 3 months duration. And we excluded patients with other systemic or ocular comorbidities and also excluded patients who had recent bereavements or recent other emotional trauma not related to their diagnosis. So for measuring anxiety and depression, we used the hospital anxiety and depression scale. Why did we use it? Number one, it was designed for primary care setting, not for a psychological or psychiatry department or OPD. It can screen both anxiety and depression in a single questionnaire format. It is very easy to use, and also it is available in Hindi and has been used in other ocular diseases in India. So we included 104 patients in 8 months' time. Their median age was 25, and like a typical keratoconus profile, they were mostly males living in urban areas, and they were either students or professionals. If you look at the keratoconus profile, their diagnosis was there for a median of nearly 2 years. Most of them were either moderate or severe keratoconus. Surprisingly, very few had binocular vision impairment, and a majority of them were being treated with glasses, contact lens. Some had undergone cross-linking, and few had undergone PK or DALC. If you look at the prevalence of anxiety and depression, around 37% of patients were either borderline anxious or borderline or definite anxiety was detected, and around 77% of them had either borderline or definite depression scale score positivity. If we look who were more likely to be anxious, patients who were coming from rural areas were more likely to be anxious, patients who had married were more likely to be anxious, and patients who had moderate or who had severe keratoconus were more likely to be anxious than the others. And who were likely to be depressed, that was patients who were more educated were likely to be depressed, patients who had severe keratoconus were more likely to be depressed, and surprisingly patients who had undergone cross-linking were more depressed than the others. So is the depression or the mental anxiety or mental depression in patients in keratoconus more than the normal population? It is definitely more than the normal population. If you look at normal Hindi school-going or college-going students in India, the depression of keratoconus that we measured of 72 and 77% were definitely higher. And it was also higher than other ocular comorbidities like vision impairment, low vision, glaucoma, ARMD, and fuchs corneal dystrophy. So most of the patients were either anxious or depressed, like patients from rural areas and who were less educated were probably because they could not understand or comprehend the disease very well. Patients who were married were probably more anxious because there were concerns of family welfare. Patients who had undergone cross-linking, probably this was because they had undergone an operation for the first time. They were otherwise a healthy individual and they had inadequate coping mechanisms for this. So what is the carry-home message? We should screen patients with keratoconus for anxiety and depression. Screening can be done with HADS, which is an easy tool to use. And we can improve our counseling techniques, give positive reinforcement, and help these patients in understanding a disease. And patients who are found to be frankly depressive or anxious can also probably get a psychiatric care or psychological counseling in addition. Thank you.
Was there any subjective assessment of the anxiety or a depression? Like how did you rate that, whether it was a mild, moderate or severe depression or anxiety?
No, the HAD scale has only 3 scales. Either it is normal, then borderline, if the score is between 8 to 10, and if it is more than 10, then it is frankly this thing what called either anxiety or frank depression is present. So it doesn't measure the anxiety as mild, moderate or severe. It is a screening tool. So that differentiates people who are either with the disease or they are either out of the disease. So for the further this thing, because in an eye clinic, this is what you can do, either screen of the patients, and if we found them to be, having either frank or higher scores, then you refer them to a psychologist for their further counseling, further stratification and further treatment.
That's what I wanted, like you've done a very good job. But it was just an arbitrary assessment of whether anxiety...
It was not arbitrary, because we use the HAD scale.
What all things you have taken into consideration? This patient is having a...
We took all these parameters that we discussed. I did not discuss because of constraint of time the non-significant parameters. But this is not an arbitrary this thing. The HADS is a definite instrument. There are multiple tools in psychology to assess depression and anxiety. Why we chose HADS? One, it has been designed for a primary care setting. So it need not be that we are using in the cornea clinic, it can be used in other settings also. Once you screen out the patient, then you can take the subsequent steps. Thank you.